So this boy actually wanted to become a doctor and do something better than this. And various reasons in India, he couldn't become a doctor, and instead he became an engineer. So he was a little disappointed, but until he met a very great person. And this great person told him, if you are a doctor, you can reach out to thousands of patients. But if you're a doctor's doctor, helping them with technology, you can reach out to thousands of doctors who in turn can help millions of patients. So that's what he took as an inspiration in his life and developed and invented a device when he was 21. So you might be curious who this great person was. He was none other than His Excellency, the former President of India, Dr. APJ Abdul Kalam. And of course, the 13-year-old boy is the same person standing and talking in front of you with 30+ years now. And the device that I invented is the Viscope, the visual stethoscope, which is the first of its kind, continuous, real-time, high-definition. It's a coincidence, HD, it's also a company name, but it's truly high-definition sound quality, and it's a visual stethoscope. So unlike a current stethoscope where you can just see you can just hear the sounds, here you can actually see what you hear. And as you can see over here, there is a visual display which actually shows you the heart sounds, as well as if you have any murmurs that are present, it actually shows that. And the sound amplification is more than 30 times, and it can actually have the ability to detect murmurs and analyze the sounds and save them in a PC for serial studies and follow-up, and also document the report, because that's one of the biggest problems with the stethoscope. It would never give you an opportunity to document. There is no paper trail. And today in this modern evidence-based, with all the legal suits and things like that, we want to document things and compare them year after year, how the patient's abnormalities have progressed and so on. So that's where this really helps you do that. And also, it gives you the ability to transmit these sounds, because that can truly enable next-generation telemedicine as well as home healthcare applications. It really increases the experience. Now, Dr. Schiller has been using this device later in his talk. I don't want to take his thunder away, but he says that it's almost like, it's a new experience altogether. There's so much happening. And in the past, doctors, when they auscultate, they always used to close their eyes and listen to the sounds, whereas now it's almost like opening up their eyes. They would like to see what's going on with all the dynamic waveforms and so on. So that really gives the advantage of one more sense. And obviously, the sensory perception of the human eye is much more accurate than the human ear. And it requires years of training to master the art of auscultation. And that's where, by bringing in the visual concept, it really helps in mastering this dying art, per se, into a science, where you can really look at what's happening in terms of the heart sounds, the murmurs, and things like that, right? And it also enables in the detection of chronic diseases, and particularly at an early stage. Now, we have done some studies both here at UCSF as well as in India, and I'll share some of the results later in my presentation. But we are actually coming up with better and better algorithms which can really help in detection of these heart diseases better. And it's also an alternative low-cost mode for triage as well as for serial studies. Because today, the only other option apart from the stethoscope is the ultrasound echo. Now, while it may be available very easily in the developed world, but in developing countries like India, it's very hard to have an ultrasound echo machine available in a rural village. And even if we do, it's very hard to find a well-trained sonographer to acquire these images as well as interpret them. So that's where we need to have an accessible and affordable solution, and that's where this device really helps in that. And of course, the most important application here is the teaching, because a lot of students find it very hard to actually master the skill of auscultation. And there are, of course, jokes going around, like when the professor asks, do you hear a S3 sound? And all the students nod their head, but they sometimes hardly hear them because they are very low frequency sounds and so on. So that's where this really facilitates teaching, because it gives you a visual display, so they can actually learn from that. So let me take you through some of the technological aspects here. Now, the biggest problem why the so-called phonocardiography lost its popularity in the 60s is because there was too much noise, okay? And these kind of applications work with the principle of GIGO, garbage in, garbage out. That means if you have a noisy signal, if you analyze them, you're going to get an erroneous output, right? So that's where it's very important to remove the noise at the point of source itself. Now, HD Medical has worked on this area for the last 10 years, improving and almost perfecting this sensor technology, where we have tried to use modern digital signal processing techniques and modern sensor techniques to really perfect these acquisition of the hard sounds, right? And that greatly helps in the next step, which is the analysis. And the analysis is very important because as engineers, we can develop algorithms, but until we know the theoretical aspects, it's very hard to understand and develop algorithms. So we used to read Brownwald books and other books, bedside cardiology and so on, to master these algorithms. And that's where we derive a lot of guidance from working with people like Dr. Schiller and other cardiologists worldwide. So the important concepts are, how can you extract the various components of heart sounds without using an external timing reference? And by that I mean an EKG signal, because the ECG becomes very complicated when you want to add leads and put gel and things like that. It becomes even more cumbersome for us to use for our screening application. So that's where we have developed algorithms which can actually analyze the heart sounds. For a start, we actually create an envelope of all the heart sounds that almost acts like a QRS waveform, right? So that's almost like an ECG QRS waveform. So from there, we can actually look at the first heart sound, the second heart sounds, and then in this trace, you will find that in these 4 different colors, you will see the systole region, the diastole region, and then the first and second heart sounds. Now, once you do a good job of the extraction of various components, it's almost like more than 70% of the diagnosis is already done, because a lot of pathological murmurs exist in the diastolic area, right? And there are some murmurs which are innocent, which are mostly in the systolic area. So once you differentiate between systole and diastole, and then separate the S1 and S2 complexes, then you can actually extract out the murmur. And that's where we go to the next step of both visually presenting the information as well as detection of the murmurs. Now, talking about the visualization here, of course, it doesn't provide you with an anatomical image of the heart, but we believe that non-specialists, particularly general physicians, nurses, and paramedics, they find it very hard to actually interpret the moving image of an anatomical heart, right? So that's where it's easier to actually interpret a functional imaging of the heart, which is where the visualization is very important. And once they see this, they can actually narrow down whether it's a systolic murmur, diastolic murmur, and then based on the auscultation points, they can detect whether it's an aortic stenosis or a pulmonary stenosis and things like that. So that really helps in better diagnosis by the doctor. And our idea is no way to actually replace the doctor's brain, which we can never, ever do, but it really is a tool that can help facilitating better diagnosis at an early stage. Now, going a bit further on the technological aspects here, now, the fundamental breakthrough that we have achieved here is that we have collected more than 25,000 heart sound in our database from various clinical studies that we have done in India, Asia Pacific, as well as in the US. And based on that, we have actually found the fundamental frequencies of every characteristic of murmurs, like starting from the S3 and S4, the third and fourth heart sounds, which are in very low frequency. And I just wonder how doctors are trained to even listen to such low frequency sounds. It's very difficult because they're very minute sounds. And as you all know, the human hearing response starts well above 60 or 100 hertz, right? And that's where these sounds are very hard to detect. And then comes the S1 and S2 sounds. And whereas there is a bit of overlap here with the stenotic murmurs, the low frequency murmurs, which are usually caused by the blockage of the heart valves, both the aortic and mitral valves. And then the regurgitant murmurs, which are slightly more higher frequency. Traditionally, they are taught as the blowing murmurs, right? Those are the regurgitant murmurs. And then the PDAs, the VSTs, the much higher frequency. But of course, as we move higher in the spectrum, there is interference coming from all the ambient noises, particularly the speech as well as the breathing, coughing, especially in children. The crying is a big problem. When the kids cry, it's very hard to auscultate, right? So those are practical challenges we face. But of course, in the adults, to avoid the breathing sounds and wheezing and all that stuff, we can ask them to hold the breath and things like that. But still getting the noise removed is the key. And that's where we have developed algorithms that can separate all these components. And we almost come up with like a murmur detector threshold, which will separate the first and second heart sounds from the murmurs. And that's a very important step, because without having to use any other ECG or any other external timing like a A wave or things like that, we are able to separate these various complexes of the heart sounds. So some of you might have seen the demo of the device towards the end. We have set up a table there. But just to give you a feel for how this device is actually how it works. Basically, you can see a visual display where we have two traces. The bottom trace is what we call the bell, the traditional bell, or the low-frequency trace. And then the top trace is the diaphragm. But where the bell helps is actually to visualize all your heart sounds, the S1, S2, S3, and S4. Whereas the top trace is more the higher frequency, and we have extracted using modern digital signal processing and filtering techniques, where we've extracted and presented the murmurs there, okay? And then, again, traditionally, in the conventional stethoscopes, you can twist the stethoscope to switch between bell or diaphragm mode. And again, thanks to all the DSP technologies, we actually have a digital toggle button here. When you press this, it switches between bell, diaphragm, or even a wide mode. And the wide mode helps in listening to lung sounds, as well as various other higher frequency sounds. Of course, you can adjust the audio gain 3 times, and then the visual gain almost up to 10 times. So altogether, more than 30 times amplification is possible. And the best part here is that, like a cell phone, you can actually recharge the device overnight. And 5 hours of charge will give you more than 8 hours of continuous usage, which is good enough for almost 2 days of continuous clinical practice, right? And there is a USB port here, which you cannot see in this, but the USB port also lets you transmit these sounds once they are saved into your computer for you to archive them for future serial studies and things like that. And the last button here is the one that actually basically is the freeze button, which acquires the sounds. Now, in this current version, it acquires whatever you see on the screen, which is basically 2.5 seconds. But you can actually save 4 such 2.5-second loops. But in our advanced versions, that is not FDA approved here yet, but you can actually save up to 10 or 20 seconds of waveforms and start analyzing them with our murmur detection algorithms and so on. So this is what you hear in a normal heart sound, just the lub-dub sounds. And you can see very clearly the S1, the S2, so systole, diastole regions. It's very easy to visualize here. And then, of course, not much shown here because there aren't any murmurs. But if there are any murmurs, it will sound like this. So it's a blowing murmur, which is aortic regurgitation. And you can see here the S1, S2, and the murmur starts exactly after the S2. So it's an early diastolic blowing murmur, high-frequency murmur, right? So the algorithm actually separates the heart sounds from the murmurs, right? So once you see that, you can actually time the murmur and almost come to a conclusion on what the diagnosis would be. And of course, at this point, we don't want to provide the diagnosis because it's still a doctor's tool, and it will help the doctor in coming up with the diagnosis. But in future versions, particularly for nurses and paramedics to use, we are actually coming up with automated algorithms, differential diagnosis, and so on, that will greatly help in screening, especially in mass rural medical camps and things like that in developing countries. So the cardiologist will understand what this is. The split heart sound. So this is an atrial septal defect, the ASD, where you can clearly hear the wide fixed splitting of the second heart sound. Now let me elaborate on this a little bit more. Traditionally, the normal split is defined as something less than 40 milliseconds. Not 40 seconds, 40 milliseconds. Whereas the wide fixed split is above 40 milliseconds. Now, of course, if you are trained for tens of years, you can actually differentiate the normal versus abnormal split. But what we have done from a technology platform point of view is that not only we have improved the sound quality greatly so that you can clearly distinguish the splits, but in our software, you can actually acquire these sounds, and we have this tool called as calipers. Once you turn them on, it actually presents these 2 lines, the measuring scales. You can exactly measure the split to be 70 milliseconds, right? And this way, you can differentiate between paradoxical splits, wide splits, and so on. And of course, if there is an opening snap, which is 90 milliseconds, slightly further away for a mitral stenosis, you can actually differentiate that. Whereas if it is a third heart sound, it's an S3 here at 130 milliseconds. So you can exactly visualize that in the screen. Because it's very hard to hear these S3 sounds, right? And that's where this device helps in not only hearing it better, but also visualizing it and measuring it so that you can differentiate between a wide fixed split or an opening snap or an S3 or any other gallops or any other sounds, pericardial rubs and so on. And this is the S4 sound. Again, you can time it. And there is a group of researchers in Japan who are studying the impact of the distance between the S4 and the S1. And they're trying to prove with evidence that if it's beyond 70 milliseconds, it could lead to some clues in detecting either a heart failure or even ACMI. Now, if that is actually proven with clinical studies, we have the platform technology to actually make it possible in terms of detection and screening, right? So that's where it becomes very important. And lastly, here I have an MVP waveform here. So, and this is of personal interest for me because I had an MVP when I was young. So too bad this technology wasn't available at that point where you could actually see it. Now, Professor Nishimura, some of you may know him from Mayo Clinic, so he always recommends that it's too subjective to measure the 2 millimeter distance in terms of the prolapse, whereas if you have a patient whom you can hear the ejection sound, and from sitting posture to standing posture, if the ejection clicks moves further away, then you can almost confirm that this patient has an MVP. So that, again, becomes very easily possible with our technology, right? In terms of future upgrades, as I mentioned before, we not only want to detect these various components, but we also want to separate out these murmurs and provide the ability for the doctor to actually confirm yes or no, whether this is indeed a murmur or not. Because sometimes it could just be some coughing or some other external sound that could appear as a murmur, which are beyond the technology's control. So that's where we can actually provide the doctor with the ability to do so. And we also have in future versions coming up on smartphones, so you can actually very easily do the iPhone trick to expand, zoom in, as well as select and things like that, right? And we actually almost provide a difference between the device diagnosis versus the doctor's diagnosis. And in future, we're also looking at grading the murmurs. And Dr. Schiller here has advised us that aortic stenosis is such an important disease, almost like the disease of the century. So if we can grade the aortic stenosis as mild, moderate, and severe, that could be very useful in terms of serial studies and analyzing a patient's condition and things like that. In terms of our current research, which is actually part of our future product pipeline, we are actually working on enabling differential diagnosis of murmurs. And this may not be very much required for cardiologists, but certainly for general physicians, nurses, and paramedics, this could be very helpful for quick triage decision. And we are adding a simultaneous ECG so that it not only helps in the visual display in terms of timing with the QRS waveform, and by adding an ECG display, I'm not even suggesting multiple leads, gels, and so on. We want to make it into an integrated ECG device so that when you put your chest piece on the chest wall to listen to your heart sounds, it also simultaneously acquires your ECG trace, right? So that can be very helpful in looking at various electrical information as well as the beat-related information and so on. And we're also looking at integrating the heart sounds with echocardiogram images. Now, Dr. Schiller later is going to present about some of the things that he has found out in terms of using this technology in conjunction with ultrasound echo, particularly for some of the blocks and things like that. So definitely we find this as a complementary technology to ultrasound echo. There is no way we're going to claim that this will replace an ultrasound echo, which we'll never do. It is just going to complement the ultrasound echo because fundamentally what it does, it brings back the clinical skills, which are actually becoming very much a dying art today. So that's where the emphasis is to go back with modern technology, going back into the clinical aspects, clinical skill sets. And finally, also, we are looking at enabling gating of multiple imaging modalities, even like MRI and CT, because today the gating is primarily based on ECG. And if there is an electromechanical dissociation, the heart sounds would be a better gating combined with ECG. So that's what we're working on. And in terms of our product line, we are looking at enabling next generation telemedicine and home healthcare applications. Now imagine a scenario where if you are a home user and then you're having an uneasy feeling and you don't know whether it's really a chest pain or a real defect, or is it the case where you just ate too much garlic overnight, right? So that's where you need some real-time detection and triage of what the condition is. And we are trying to develop applications where every home user has a smartphone today, and then if the smartphone can have the ability through Bluetooth capability to pick up some of these parameters in real time, both heart sounds, ECG, and so on, and transmit it over a cloud, and then the cloud has these algorithms running there, and if the algorithms find that there is a defect, it will actually stream these waveforms to a cardiologist on his smartphone, and he can not only see the waveforms, but also listen to them, almost teleauscultation for the first time, right? And that can give him enough information to trigger an EMS or not for the patient, right? So those are the next generation applications that HT Medical is focused on developing. In terms of clinical trials and references, we started off in 2001 when this company and the technology was initially incubated with the Singapore government, and we had trials in KK Hospital, which is one of the largest pediatric and women's hospitals in Singapore, and then we did some studies at Monash University in Australia, and the real transformation for this technology came when we started working at UCSF under Professor Nelson Schiller's guidance. We had one publication from International Journal of Cardiology, and we also had multiple studies in India for the detection of murmurs, where we showed sensitivity and specificity in the high 90s, in terms of detecting murmurs with ultrasound echo as a gold standard. And we have also done a lot of camps in terms of screening patients, both at public healthcare centers. And recently, we have done a study, which is by far the largest study in India, where we actually screened close to 30,000 children over a period of 3 months with just 10 nurses involved. We trained them with our device, and they have screened all these patients, all these children, and they found a very high incidence of 0.7% of cardiac murmurs. So the government of India is actually working with us in terms of implementing this in all the National Rural Health Mission programs and so on. So we believe this device can greatly help in terms of enabling next generation screening and triage.